So today we have the second part of the presentation, which was previously uploaded by the name of Pulmonary Embolism versus community acquired pneumonia. So, or infarction versus community acquired pneumonia. This was actually a patient of 35 years of age, and he presented with left-sided chest pain. He was having peripheral vascular disease and intermittent claudication. So we were of the opinion that probably this patient is suffering from the infarction and not the infection. Actually, the points which were in favor of the infarction were this patient just presented with left-sided chest pain with no fever. The other point was this patient was having the normal blood CP with no raised TLC and neutrophils level. The third point was this patient was having a clear-cut history of peripheral vascular disease with amputation of the left second tube. And the fourth point was this infarction, the chest X-ray finding was peripheral and it was almost wedge-shaped, and this patient was having hemoptysis without any sputum. So all these points were actually favoring the infarction and not the infection. But this patient improved with antibiotics, and probably the oxygen, which is the main determinant for preventing the hypoxia, this patient improved. So we traced this patient, and we will show you the first scan which was taken for the pulmonary infection, and we did the CTPA of this patient to confirm whether this is an infarction or this is an infection. So we will focus on the first scan, which already I have uploaded in the previous presentation. Look at this scan. We already described that this patient is having pruning of the vessels. There is pruning of the vessels, and this patient is having an area of air bronchogram and area of air bronchogram, and we focused in the previous presentation that this patient is having small cyst. These small cysts are actually reflecting the infarction. Now we will move to the CTPA of this patient. So the CTPA of this patient is actually reflecting features of the pulmonary hypertension and infarction. This is the mediastinal window. If you focus, the patient has a larger pulmonary trunk. This is actually a large pulmonary trunk. The diameter of the pulmonary trunk is more than the diameter of the ascending aorta. This is ascending aorta and this is the pulmonary trunk. So the pulmonary trunk is almost of larger diameter as compared to the ascending aorta, which reflects that this patient is suffering from pulmonary hypertension and maybe secondary to the chronic thromboembolic phenomena. Now we will take the scan, the CTPA of this patient, which is reflecting the abnormality. With that we were suspecting this is the CTPA. Look at the CTPA. You can appreciate the vessels. These vessels are clearly appreciable. If you focus on the CTPA and the infarcted area, this is actually the infarcted area. Focus this. This is actually the infarcted area, and look at this dark abnormality, the dark spot, which is the clotting, the filling defect in the segmental pulmonary artery. Look at this. This black area is actually a filling defect which is reflecting the infarction. If we move to the other parts, we can appreciate this filling defect as well here. Look at this. This is very clear in this part. A filling defect is appreciable in the left lower lobe and is very clear. So this is actually, now look at this pulmonary trunk. The pulmonary trunk is again very dilated as compared to the ascending aorta. So this patient actually had a strong suspicion of pulmonary infarction versus infection. So the CTPA confirmed that this patient is suffering from the pulmonary infarction and not infection. So this was interesting, and the patient's treatment is quite different. The infarction needs anticoagulation and the infection needs antibiotics. So we have put the patient on Clexane 60 mg BID. Thank you very much for watching. Consult your friend.